Hello. Now I would like to invite our respected chairperson, Dr. Sandeep Rai sir and Dr. Rahul Bakshi sir to kindly come on the stage and grace the session. May I invite Dr. Shiddharth Gosavi from Bangalore. Today's topic is Tirzepatide versus GLP-1 RAS. Please welcome Dr. Shiddharth Gosavi sir.
Good afternoon, everyone. Today I will be speaking on Tirzepatide versus GLP-1 agonists. Not all incretins are equal. So we all know that oral glucose triggers incretin effect, a greater insulin response than IV glucose. GLP-1 and GIP account for 50 to 70% of the postprandial insulin secretion. However, in type 2 diabetes, GLP-1 response is partially preserved, whereas GIP response is markedly impaired. So, glucagon-like peptide 1 is secreted from the intestinal L cells. Actions are glucose-dependent insulin secretion, glucagon suppression, gastric emptying delay, hypothalamic satiety signaling, and cardiovascular anti-inflammatory effects. The endogenous T-half is 2 minutes, which is what drove the GLP-1 agonist development. The first generation drugs like exenatide and lixisenatide are short-acting and focus on postprandial focus. The second generation drugs like liraglutide, dulaglutide, and semaglutide are long-acting and lead to a stronger HbA1c and weight reduction. Cardiovascular outcome trials also established cardiovascular benefit. However, the limitation was that the HbA1c reduction was only 1 to 1.5% and weight loss was only 4 to 6 kgs. Many patients still failed to reach the HbA1c less than 7 or meaningful weight reduction. So the question was, can incretin signaling be amplified? So here comes the glucose-dependent insulinotropic polypeptide, which is secreted from the K cells intestine, the duodenum and the jejunum, and drives the insulin secretion, lipid metabolism, and appetite regulation. So GLP-1 activation in turn restores the GIP responsiveness. Tirzepatide with a half-life of 5 days, which comes in a dose of weekly subcutaneous injection of 5, 10, 15 mg and 2.5 mg. So the gut-derived hormones augment the insulin secretion in a glucose-dependent manner. So as we know that Tirzepatide is also known as a twin cretin, a novel dual GIP and GLP-1 receptor agonist, integrating both incretin actions into a single molecule. Dual incretin agonism unlocks metabolic effects that single receptor GLP-1 agonist cannot fully replicate, improving glycemic control and weight loss beyond what GLP-1 agonists achieve alone. As we said, the GLP-1, there is a glucose-stimulated insulin secretion, glucagon suppression in hyperglycemia, slows gastric emptying, promotes satiety and weight loss. In GIP, there is a stimulation of insulin release post-oral glucose, may increase glucagon in hypoglycemia, historically considered less effective in type 2 diabetes, but is reactivated when co-activated with the GLP-1. So this co-activation underpins the synergistic insulinotropic and anorectic signaling that defines tirzepatide's mechanism. So there's a modulation of the adipose tissue insulin sensitivity and there's a partial attenuation of GLP-1 associated nausea in these patients. This is a comparison table between GLP-1 agonists versus tirzepatide. We can see that weight loss and cardiovascular effects and glucagon suppression and gastric emptying, all of that was much greater. So this is the important SURPASS clinical trial program. 5 pivotal phase 3 trials investigated tirzepatide across the full type 2 diabetes treatment spectrum. And we're going from placebo to insulin add-on as well. So SURPASS 1 trial compared tirzepatide with placebo, where the key result was a HbA1c reduction of 1.9 to 2.1% and weight loss of 7 to 9.5 kg in the tirzepatide group compared to the placebo group. So the take-home message was strong glucose and weight reduction as well as in monotherapy. SURPASS-2 trial compared tirzepatide with semaglutide 1 mg head to head. So there was a greater reduction of HbA1c of 2.46% and weight loss of 12.4 kgs in the tirzepatide group, therefore demonstrating superiority over GLP-1 agonists. SURPASS-3 trial compared tirzepatide with insulin degludec, wherein there was a HbA1c reduction of 2.37% and weight loss of 12.9 kg in the tirzepatide group. So there was a better glycemic control when we compared to basal insulin group. SURPASS-4 trial compared tirzepatide with insulin glargine, and there was a superior HbA1c reduction. 91% of them reached HbA1c less than 7, therefore effective in both advanced type 2 DM and cardiovascular risk reduction. SURPASS-5 trial added tirzepatide and insulin glargine versus the placebo group. There was a HbA1c reduction of 2.23 to 2.59% with a weight loss of 6 to 11 kgs. This works best in patients who requiring basal insulin. So SURPASS-1 trial was a 40-week randomized placebo-controlled trial in treatment-naive type 2 DM patients. As I summarized the results before, peak A1C reduction and peak weight loss and A1C less than 7%, and 52% of them also achieved A1C levels less than 5.7%. So it significantly improved glycemia and body weight compared to placebo. SURPASS-2 was a 40-week open-label active control trial comparing tirzepatide of both 5, 10 and 15 mg against semaglutide 1 mg weekly. It outperformed at every dose, reaching a A1C reduction of 2.46%, weight loss of 7.8, 10.3 and 12.4 kg versus 6.2 kg in semaglutide, up to A1C reduction up to 92% in the tirzepatide group. Normoglycemia A1C less than 5.7, 51% of the tirzepatide group. Again, there was superior weight reduction. SURPASS-3, there was a superior A1C reduction and weight loss at all tirzepatide doses versus basal insulin degludec. Up to 93% achieved A1C less than 7% and 48% reached A1C less than 5.7%. In SURPASS-4 trial, high-risk CV participants on oral agents, the A1C reductions was observed to be 2.24 to 2.58% versus 1.44 the glargine group. There was a weight gain importantly in the insulin glargine group of 1.9 kg. So tirzepatide offered the dual benefit again of glycemic control and weight reduction. So tirzepatide retained the potent glycemic efficacy even when added to glargine insulin. Okay. As I said before, 97% reduction in HbA1c less than 7%. 62% of patients experienced a HbA1c reduction of less than 5.7%. So again, there was a greater A1C reduction compared to semaglutide. Weight reduction also was greater in the tirzepatide group. So important adverse events which we should know. It can cause pancreatitis, gallbladder disease. Some of them are known to trigger medullary thyroid carcinoma. And of course, the most common GI side effects are nausea, vomiting and diarrhea. Rates may be higher marginally in the tirzepatide at maximal doses due to potent appetite reduction. Slow dose titration mitigates the severity. Low intrinsic risk of hypoglycemia and monotherapy due to glucose dependent mechanism. It only increases when combined with insulin or sulfonylureas. So therefore, the dose adjustment of those agents is recommended. Again, dedicated cardiovascular outcome trials for liraglutide and dulaglutide have demonstrated significant reduction in major adverse cardiovascular events. Okay, and there was no inferiority when they used the tirzepatide group. SURPASS CVOT data also demonstrate non-inferiority in the data versus dulaglutide for major cardiovascular events. GI side effects were more frequent. Evidence continues to evolve. So here the mechanisms underpinning tirzepatide's superior efficacy. There's a dual GIP plus GLP-1 receptor activation producing additive and possible synergistic insulinotropic signals, amplifying beta cell response. Adipose tissue effects wherein it modulates the adipose insulin sensitivity and lipid metabolism, contributing to improved body composition and potentially attenuating GLP-1 induced nausea. Combined receptor activation augments hypothalamic and peripheral satiety pathways, driving greater caloric restriction and more substantial weight loss. Postprandial glucose control there was a greater improvement, and insulin secretion kinetics likely explain the higher rates of normoglycemia observed across the 5 SURPASS trials. So, which patients would benefit the most? We must consider tirzepatide only when there is a robust A1C reduction required alongside meaningful weight loss. Prior GLP-1 agonist therapy has not achieved glycemic or weight target. Obesity with cardiometabolic risk warrants the weight-centric pharmacotherapy. Intensification is needed without adding the insulin burden. So, still GLP-1 agonists remain foundational when established atherosclerotic cardiovascular disease requires a proven MACE-reducing agent. Cost access or reimbursement constrains the therapeutic choice, and patient is well established and well controlled on existing GLP-1 agonists. But the cardiometabolic profile of tirzepatide is increasingly promising, and CV outcome data continues to be matured. Again, the dose initiation is 2.5 mg weekly starting dose to minimize the GI side effects during the introduction phase. Can go up to 5 mg, 10 mg and 15 mg weekly as maximum dose. Regular A1C, body weight and GI tolerability assessment. Watch out for pancreatitis and thyroid disorders and gallbladder disease. So, the take-home messages. Tirzepatide integrates the GIP plus GLP-1 activity, producing synergistic metabolic effects that exceeds GLP-1 monotherapy. Across SURPASS 1 to 5, tirzepatide outperformed placebo, semaglutide and basal insulins in A1C reduction and weight loss. Adverse events are broadly similar to GLP-1 agonists, predominantly GI. Management with slow titration. CV outcome data confirm non-inferiority with metabolic advantages. It is a new benchmark in incretin therapy, also called as twin cretin. Also, I would like to add, in pregnancy and lactation, especially if patients are already on tirzepatide and they get pregnant, they must stop tirzepatide immediately and switch to metformin and insulin. However, if they're yet to conceive and if they're planning the conception, the 2 months before the pregnancy planning, they must stop the tirzepatide. And it is generally avoided in lactation. So, the incretin era is evolving. So, emerging triple agonists also are on the horizon, and mechanistic frontier of cardiometabolic therapy and pharmacotherapy continues to advance. Thank you.
Yeah, thank you, Dr. Shiddharth. That was a very nice presentation. Which conditions do you think the single GLP-1 is more preferable than tirzepatide?
Sir, if the patients are not that obese, sir, maybe that could be one this thing.
Do you think cardiac patients and renal patients, you should prefer GLP-1 rather than the dual?
As of now, the reduction in major adverse cardiovascular events has been observed with the single GLP-1 agonist itself, sir, semaglutide. But there is promising data on tirzepatide as well. So,
and what about NEON? Is it reported with tirzepatide also? And what is the incidence?
No, sir. I have not come across any data where tirzepatide is causing the non-arteritic ischemic optic nerve.
So that may be one point of relief for physicians to be, apart from the cost.
Yes, sir. Definitely.
I think, Doctor,
but
you are using
semaglutide definitely the risk has been well established, including the
semaglutide risk is established.
Yes, yes, sir.
Dr. Bakshi uses a lot of these agents.
Yes.
You can add some commentary.
No, I think a good presentation. In view of time, any audience questions?
I think the study is still ongoing, sir. Results are not yet out. Yes.
Semaglutide study is there for renal patients. So we have one patient who has post-transplant patient, and his obesity was causing the problem. The nephrologist wanted the weight to be down because diabetes was not an issue. He is not diabetic. So we searched the literature. Ozempic, I should not take the name, but GLP-1 have studies on that.
Correct.
So nephrologist also agreed to start on GLP-1 rather than the dual agent.
Okay. Thank you.
I have one patient who is on liraglutide, post-transplant, incompatible post-transplant, without diabetes, only obese, is on liraglutide and is doing well. He has reduced weight by 8%.
Okay.
Thank you, Doctor.
Thank you.